Hello, everyone. Thank you very much for taking the time to join us today for another Ortho Illinois Power Lunch with workers' compensation education and continuing education for you. And without any further delay, I'd like to introduce Dr. Neal Shah. Dr. Shah, thank you so much for taking time out of your busy afternoon to talk to us today.
Thank you, Bill, for that warm welcome. And thank you for all of you that have joined and are willing to spend a couple of your lunch hour talking about complex regional pain syndrome. It's a very common thing that I treat, and I want to just share my experience with you on what it is and what's the best way to get your patients the care that they need. Once again, my name is Neal Shah. I am the interventional pain specialist here at Ortho Illinois, working out of Elgin. I went to St. Louis University School of Medicine and did my anesthesiology residency out in Pittsburgh. Came back to Chicago to do my pain medicine fellowship out at Rush, and I have been here for a little over a year, taking care of the patients in the Elgin community and the greater Chicago area. A few things about my practice philosophy. I'm a big proponent of using conservative management to take care of patients, of really focusing and honing in on rehabilitation, physical therapy, and getting multimodal analgesia, relying on various medications to try to get patients back to their functional quality of life as soon as possible. At the end of the day, I am an interventional specialist, so I do focus on interventions to try to aid the patients in getting to the end outcome that they would like to. But I really want to just point out a few things, the last 2 points here, which is that I do my best to be as honest as I can, uphold the integrity and build a trust with my patients as well as their family members. And I give all patients advice as if they are a family member, because I want everybody to feel as comfortable as possible when they are in a visit with me. So focusing back on complex regional pain syndrome, or CRPS, if there's anything that you should take away from the talk today are the 3 points that I've listed here, which is if you have a patient you suspect has CRPS or is diagnosed with CRPS, the best way to help them is to first encourage them to get involved in physical therapy, focusing on a desensitization protocol specifically, getting them involved or interacted with a pain physician as soon as possible before their symptoms worsen. And if their symptoms are progressing beyond a point and adjunct therapies are recommended, such as ketamine infusion therapy or neuromodulation, be a proponent, be an advocate, and get the patients those therapies as soon as possible. So a little bit about CRPS. It's formerly known as reflex sympathetic dystrophy. This was a term coined back in the Civil War era when people found various soldiers and wounded people who are having peripheral nerve damage from gunshot wounds. At the time, they were having burning pain, and it was termed causalgia. A little while later, in 1900, these constellation of symptoms became known as Sudic dystrophy, and officially in 1947, the reflex sympathetic dystrophy term was coined. Now, complex regional pain syndrome is a very challenging thing to know, to diagnose, and because of that, it's challenging to know how many patients truly have it. The official incidence is unknown because of this, but nearly 200,000 patients are impacted annually. Now, one thing I can tell you is that females are more impacted than males typically, and the older the patient is, the more likely they have a chance of developing these symptoms. Oftentimes, these symptoms are not recognized early on or mistaken for some other form of injury or resolution of post-surgical pain, and thus it can go up to 30 months before appropriate care is sought. Oftentimes, 5 physicians are seen before referral to a tertiary care center. And once symptoms start to develop, they're very quickly associated with sleep disturbance, functional impairment, and even suicidal ideations. Now, within the worker compensation world, about 54% of patients who have CRPS have an active worker compensation claim. 17% of these patients have a pending lawsuit in some nature. For those of you that are taking care of these types of claims, the types of industries that typically have patients who have CRPS are people who work in the service industry, maybe restaurant workers, police officers, people who are working with heavy machinery or who have an injury because they have some sort of injury with that machinery, or high physical activity related work, so heavy labor, construction work, etc. Some common injuries that you may note, fractures, dislocations, ankle or wrist sprains or strains, nerve injuries, and crush injuries, like I mentioned earlier. But the last 3 points are the ones where we really see the development of this complex regional pain syndrome prevalent, which is carpal tunnel syndrome, foot and ankle surgeries, as well as any other post-surgical complications that relate to work around a nerve. There's 2 types of complex regional pain syndrome, type 1 and type 2. I'll delve into it in a little bit more detail in a few slides here. But big picture, type 1 is when you have a minor injury with little or no obvious damage to nerves, such as a sprain or a strain. Type 2 injury is what is more classically referred to, where you have a surgical procedure, crush injury, you have a known injury to the nerve that's impacting its function. Now, how does CRPS progress? So previous studies have shown that over 6 years, 102 patients that were studied that had CRPS compared to approximately the same number of patients that did not have CRPS, 16% of patients continued to progress with worsening symptoms even after initial forms of treatment. Almost 30% of these patients went on to become incapable of working, and we noted that the patients who have upper extremity involvement had the lowest or poorest outcomes. Usually, if patients have not improved or have not sought treatment at the 2-year mark, they will lead or develop persistent impairment. Now, why is complex regional pain syndrome so challenging to diagnose? Well, the reason for that is that it is simply a clinical diagnosis. There's not a lab test or an imaging study that can pinpoint the diagnosis. There was, in 2004 as well as in 2012, many esteemed pain physicians came together and developed a Budapest criteria, which is currently the criteria that all interventional pain physicians use to make the diagnosis. But we do rely upon a history and other diagnostic measures to help rule out other etiologies that could be at play. So this is the Budapest criteria of complex regional pain syndrome. It involves, number 1, identifying having symptoms that is disproportionate to the initial injury. And then the other aspect of it is looking at the history that the patient reports as well as the physical exam. So in order to state that the patient has CRPS, they have to report symptoms in 3 categories of the following: sensory, vasomotor, pseudomotor, and motor changes. And then on exam at the same time, you would have to have symptoms in at least 2 of those categories. So very briefly, the sensory component is usually something like allodynia, hyperalgesia, pain out of proportion to touch or light sensitivity. Vasomotor symptoms include temperature asymmetry, skin color changes, or skin color asymmetry compared to the opposite limb. Pseudomotor may include increased edema or sweating changes or sweating asymmetry. And then the motor trophic changes include decreased range of motion, motor dysfunction, which could include tremors, or trophic changes, which is changes in hair, nail, or skin growth compared to the opposite side. So we're looking for patients to report at least 3 symptoms in these categories, and then having at least symptoms in 2 of those noted on physical exam. The last point here is very important as well, which is that no other diagnosis can better explain the constellation of symptoms and signs. So this is where we rely on some other diagnostic testing to rule out other etiologies. So as I mentioned earlier, big picture for the type 1 versus type 2 CRPS. Type 1 is when there's an absence of nerve injury. This is the most common type of complex regional pain syndrome. Type 2 is when there is a presence or documented evidence of nerve dysfunction or nerve injury. When you are having patients and accompanying them to their visits, key buzzwords that should perk your interest on whether this patient is developing complex regional pain syndrome would be patients who are complaining of burning, throbbing pain at the site of the injury, patients who are reporting odd colors in their skin, blue, purple, red, especially with asymmetry in temperature, feeling like they cannot tolerate hot or cold temperature. They notice more swelling on one side. And lastly, if they're having decreased function, maybe inability to completely plantar or dorsiflex their ankle, if they're not able to ambulate for long distances, they're noticing hair or growth changes. Those would be the key buzzwords or key symptoms to keep an eye on. Now, the reason why CRPS becomes challenging to treat once it has set in is that it becomes a vicious cycle of the sympathetic system on overdrive. You have an original injury that pain fibers send signals to the central nervous system in the brain, which processes that, which revs up the sympathetic response and develops an inflammatory cascade. That's the initial response. What ends up happening is that when you have small nerve fibers that are inflamed, this sympathetic cycle continues to revolve over and over and over again. And it's very difficult to break that cycle. And this is what ultimately results in the swelling, burning, pain symptoms that the patients experience. Now, in order to diagnose CRPS, a pain physician such as myself would perform a focused history and physical exam. We would be looking for at least the criteria, the Budapest criteria for the patient to meet. Now, as far as whether to distinguish between CRPS type 1 versus type 2, when you're talking to a patient or examining a patient, it's very challenging to know whether they have type 1 or type 2. But the treatment for either of the type is exactly the same. Burning, deep, aching pain with shooting quality, hyperalgesia, these are the buzzwords for me when I'm taking care of patients who are in my office. And outside of this, if I am suspecting complex regional pain syndrome, I will look to rule out other causes of similar symptoms. So at the end of the day, CRPS is a nerve-related dysfunction or disorder. We're looking to rule out things like diabetic neuropathy, presence of radiculopathy, any discogenic disease, presence of a DVT, cellulitis, vascular insufficiency, or other abnormalities or resulting from previous surgical complications. The key thing, and this is something that's noted in many textbooks, which is pain out of proportion to the inciting injury. So many surgeons also are using this as their criteria of consideration of complex regional pain syndrome. If a patient is coming back post-operatively, they're healing appropriately initially, but maybe they're 6 weeks, 8 weeks out, 12 weeks out from a surgical intervention, and still are complaining of pretty excessive or high-rated pain, that is unlikely to be due to postoperative issues. And that is where complex regional pain syndrome may be setting in. Now, the diagnostic testing that can be used to rule out other etiologies could include an MRI of the affected area of the spine or the joint. An EMG can help rule out or rule in underlying nerve dysfunction or nerve injury. The next few tests are a little more specific. They're not often done because of how complex it is, the time and effort it takes to do it, and the cost of it. But if you would like to, quantitative sensory testing can help identify presence of the allodynia hyperalgesia. Autonomic function tests such as QSART can help identify abnormal temperature and swelling changes. And then the bone scan or bone scintigraphy can help identify abnormal bone density, which is typically seen in the first year of CRPS. But once again, I do want to reiterate, there is not a single diagnostic test that is the gold standard for diagnosing CRPS. Now, the reason why it's so important to identify these patients earlier is that the earlier a diagnosis is made, the faster or more goal-directed treatment plan can be administered. And this is why it's very, very important to get these patients into the hands of an interventional pain specialist as soon as possible. Now, the treatment of CRPS is multidisciplinary and multifocal. Part of it is looking at the rehabilitation component, where it's important to focus on desensitization to help stimulate that sensory nervous system, focusing on isometric exercises, trying to reduce the edema, peripheral electrical stimulation can help. The other aspect of it is the psychological component. Because it's a nerve-related injury, pain is out of the proportion. Many times these patients are going from doctor's office to doctor's office, and oftentimes are being told, there's no way that your pain is as bad as it is. You're making it up. It's all in your head. That takes a severe toll and leads to anxiety, depression, and loss of faith in the medical community in general. And so many of these patients do develop anxiety, depression, and need biofeedback, cognitive behavioral therapy to help them manage their symptoms and cope with their symptoms. The right side of this screen is a little bit more in terms of what an interventional pain specialist will focus their time on, which is performing minimally invasive injections such as sympathetic nerve blocks, and then depending on the response from that, very quickly escalating to higher levels of therapy such as infusion therapies or neuromodulation. At the end of the day, every patient is their own person, they have their own journey, and so it is very important to create a personalized treatment plan because no one patient has the same response to a treatment or an injury. Now, where physical therapy and functional restoration is important is that you want to focus on strength and range of motion. Typically, anybody that has a work-related injury or is coming from or after surgery likely has some sort of physical therapy prescribed, and they're likely going to work on strength and range of motion. But because CRPS is focusing or dealing with the nerves, desensitization to various stimuli is very important. This is what helps train those nerves and tries to get them reinvigorated back to their normal state. As I mentioned before, psychotherapy is very important. The single most important type of therapy that patients can undergo from a psychological standpoint is cognitive behavioral therapy. And the reason for this is that this allows patients to develop the coping strategies on how to manage their pain when they have a flare-up or when maybe they're not progressing as rapidly as they would like to. From a pharmacologic standpoint, the mainstay treatments include anti-inflammatories early on. Corticosteroids can help treat a flare or when initial symptoms are present. But the other more classic medications that are associated with CRPS management include anticonvulsants, such as gabapentin or pregabalin, tricyclic antidepressants, amitriptyline or triptyline, or SNRIs such as Cymbalta or duloxetine. Now, many patients are on opioids for treatment of these symptoms, mainly because their pain is out of proportion, it's very severe. Opioids do have a role in initial treatment of pain, but not for very long. Opioids are not a great treatment option for neuropathic pain. And the reason why many of these patients are challenging to treat is that by the time they get in the hands of a specialized interventional pain physician, they're on escalating doses of opioids, which makes it very challenging because they already have set in some level of opioid-induced hyperalgesia. Calcitonin and bisphosphonates can help in that first year of symptoms, mainly to help reduce the bone resorption that is noted. And then if patients are able to tolerate topical agents, lidocaine patches or capsaicin cream may be a great adjunct therapy. Moving on from some of these more readily available medications is something that's more newer in the market for treatment of CRPS, which is ketamine. Ketamine is an NMDA antagonist. Many of you may know of it as a sedative that's used in the ER or in the operating room for sedation or analgesia. But recent studies have shown that a low-dose infusion for 3 to 4 hours at a time has provided significant reduction of pain, especially during a flare. And this is something that we here at Ortho Illinois are looking to incorporate and are willing to offer patients who have CRPS because it's a great adjunct and it's hitting a receptor that's not very easily accommodated by over-the-counter or prescription pain medication. The more mainstay and targeted treatment of CRPS deals with doing various minimally invasive injections. As I mentioned before, that the symptoms are developing from a sympathetic nervous system response. So the best way to treat that is to try to break that cycle by doing a sympathetic nerve block. And depending on where the symptoms are, that may be done via a stellate ganglion block, which is done just here up in the neck, or a lumbar sympathetic block, which is done just a little bit lower down into the upper lumbar spine. These blocks can be done to initially help alleviate symptoms or treat a flare when that is occurring. Depending on other symptoms that may be present or depending on the length of the symptoms, baclofen pumps, Prialt, or opioids via intrathecal drug delivery may be helpful. But the single most advanced intervention that has been shown to provide relief is neuromodulation. There's two forms of neuromodulation, the traditional dorsal column spinal cord stimulator, and the more recent development, which is dorsal root ganglion or DRG stimulation, which is very helpful when symptoms are focal. So think of this for when patients have simply foot and ankle pain, hand pain, etc. Now, spinal cord stimulation is something that's done here at Ortho Illinois. We do the trial here in our office We evaluate our patients. We try to do all of our minimally invasive options first, including medications, injections. But if they're not responding to those in any efficacious manner, we may offer this as a treatment option. In order to qualify for spinal cord stimulation, patients have to undergo a clinical psychology evaluation and further imaging to make sure that they're candidates for the therapy. It's usually a 5 to 7 day trial where trial electrodes are placed in the area of interest and connected to an external battery that stimulates the nervous system, whether it's the spinal cord or the DRG. And by doing so, it's in essence scrambles the pain signals from the areas of pain before they get to their brain. So think of this as like a pacemaker for your back. If the trial is successful, which is 50% improvement or more in your pain, mood, function, or overall quality of life, the patient would move on for permanent implantation. And as long as everything goes well, patients may just need a battery change every 5 to 10 years, but can have continuous treatment with the spinal cord stimulator. Here's just some images of a spinal cord stimulator. There's various companies on the market. 4 major ones: Abbott, Medtronic, Boston, and Nevro. But typically this is what a spinal cord stimulator would look like. Centrally here you can see the electrodes in the mid-thoracic spine and the IPG, or the battery, that's implanted here in the left lower part of the picture. More recently, some companies such as Abbott have come out with both rechargeable and non-rechargeable batteries. I wanted to bring this to light, especially for patients that are more active, may not want a high profile or a large battery. This is a very small battery. It's about the size of your Apple Watch. It's implanted, and charging requires maybe 30-40 minutes once a month, or even longer than that. DRG stimulation has been done more recently for CRPS as well as some other indications, but especially when you have localized symptoms, this is a form of stimulation that looks to target a different aspect of the nervous system, but can provide some significant pain relief and could provide stimulation in just the targeted area that the patient is having pain. And here's an example of what DRG stimulation would look like. Here the patient has 4 electrodes on both sides, but typically it's done unilaterally. And some images of the intrathecal drug delivery systems. I briefly alluded to this with the baclofen or Prialt. This is an option for patients who have pain that maybe is not treated with spinal cord stimulation, or maybe they're on a very high dose of opioids. This is a system where the programmable pump has a combination of medications, and it's programmed to deliver the medications at a set rate via a flexible catheter that's placed right next to the spinal cord, actually in the cerebrospinal fluid. The nice thing about this system is that you can deliver a large amount of medication in a very small concentration, and it can provide patients some significant pain relief. The only downside to this therapy is that it is a little larger in profile of the device, and it does require more maintenance, as it requires medications to be swapped out at least every few months to prevent any major issues. Overall, as I mentioned earlier, CRPS requires more multimodal, multidisciplinary treatment. You want to work with the surgeon if the patient is a surgical patient. You want to work with the clinical psychologist, as well as using various types of medications to help treat their pain. And you want to utilize all of these therapies simultaneously to get the best results. Now, for patients who have CRPS, it's very common for them to have symptoms that continue to progress. Periodic sympathetic blocks may be required. If they have a neuromodulation device implanted, it may require fine-tuning. But one thing I did want to highlight is that if symptoms start in one limb, it is not uncommon to find symptoms travel to a contralateral limb or even to another part of the body if CRPS is not treated effectively. And so this is something to be very cautious about, especially on patients who may have had symptoms on for more than 2-3 years. And because of the progression and prognosis of CRPS, early intervention is the single most important thing any of these patients can do to try to prevent these symptoms from progressing. Now, why is an interventional pain management physician important to this treatment team? Well, number one, we're the first-line specialists for CRPS. Any interventional pain physician is specifically trained to recognize, evaluate, and manage the symptoms of CRPS in a more cost-effective and targeted manner. We have the ability to provide advanced pain management options such as the injections, as well as the other more advanced options such as neuromodulation. And typically, if caught early, especially in younger patients, conservative measures with some injections may be enough to restore function. The longer the patient goes without treatment, the higher chance they are to require things like ketamine infusion or neuromodulation device implantation. I wanted to bring this back, the point that we had earlier on. If there's anything you can take away from my talk today, it would be to encourage your patients who may have CRPS to participate in therapy with desensitization protocols in place. Get those patients evaluated by a pain physician to rule in or rule out a diagnosis of CRPS. And please advocate for them to have access to the advanced therapies such as ketamine infusion and neuromodulation. A little bit towards the end of my talk, I just want to conclude with a few other things that I do. I do independent medical exams for various chronic pain conditions. CRPS is one of them, so more than happy to work with any of you if you have patients that you would like me to evaluate for. Outside of nerve-related pain, I do treat complex regional pain and complex pain in general, looking mostly in spine, neck, low back, pain as a result of an MVA. But I also do treat other joint pain, side joint pain, hip pain, knee pain. And like I mentioned earlier, I am, at the end of the day, an interventional specialist. And so I do a lot of my treatment is focused on multimodal analgesia, but injections, I have listed a few different types of injections that I perform, as basic as trigger point to SI joint injections to the more advanced neuromodulation therapies. I do the full variety of that. So I wanted to thank you for your time and joining me to listen about CRPS and how it can impact your patients and what can be done about it. Like I mentioned, I'm here out in Elgin at Ortho Illinois. Work with a wonderful team here with my clinic lead, Jason, my clinic flow, Julie, and my scheduler, Lisa, whose contact information is there. Feel free to contact me with any questions you may have. My email and phone number are up. Thank you.
Perfect. Thank you, Dr. Shah. Great presentation as always, and I appreciate you taking the time to join us today. Now, for any questions about workers' compensation, referrals, or to learn a little bit more about our Fast Track program for injured workers, please see our website at orthoillinois.com and click on Employers. In Algonquin, Elgin, McHenry, and the greater Chicagoland area, please call Paul Strandquist, and his number is 815-847-7088. For Rockford and North Central Illinois, please call me, Bill Collar, at 815-847-7044. Dr. Shah, we have a bunch of questions, so I want to get to a couple of these.
Sure.
First question, now why is, and you just covered a lot of this, but why is CRPS so challenging to manage?
The main reason why CRPS is so challenging to manage is that it's often overlooked. Many of these patients are in primary care office, in their surgeon's office, thinking that they're just recovering, they're just having some swelling. Meanwhile, they're developing CRPS. And by the time that the patient gets sent to an interventional pain physician, the symptoms have been on for 18 months, 24 months. And kind of from that graphic that I showed you about the sympathetic system, that sympathetic system has been just consistently revving the entire body up, developing inflammation at the nerve root level, at the small nerve fiber level. And once that cycle has set in, it becomes very, very challenging to break that. And oftentimes, because the patients are complaining of very high level of pain, they're placed on higher and higher doses of pain medication. And so they develop their own level of opioid-induced hyperalgesia from that. So you're kind of battling two different things at the same time, which just makes it more challenging to fully break the cycle and get the treatment that they need.
Got it. Well, I've got a question here, and this is going to be education for me as well, because I didn't realize this was the thing, if it is. What do you think of scramble therapy? Are you familiar with that?
I'm not too familiar with scramble therapy.
Constance, if you want to maybe add a little additional information in there, that would be helpful. Kelly asks now, and we talked a little bit about ketamine before we went live here. How long does the pain reduction last following a ketamine injection? And to be clear, too, it's not a ketamine injection, it's an infusion, which is a little different.
Correct.
If you could explain that.
Yeah, so whenever you're looking to deliver ketamine for chronic pain, specifically complex regional pain syndrome, usually you want to try to deliver it over 3 to 4 hours. And the reason for this is that you want to be able to give the patient a sufficient dose of ketamine. Typically, this could be anywhere between 200 to 300, 350 milligrams. And so you need to deliver it at that low infusion rate so that they don't have the psychotic episodes, hallucinations that may happen if you give ketamine too quickly. It's a great question in terms of how long that pain relief can last. Every person is different, but typically they could have over 50, 60% or more reduction in their pain, which can last for a few weeks to a few months. Oftentimes you do have to do a few infusions, approximately 1 or 1.5 weeks apart initially to get that into their system. Again, you're basically trying to use ketamine to, in essence, do a neuromodulation from a chemical perspective at the brain level. So if you can do 2 or 3 infusions in a row, then they may be able to space out their booster infusions as and when that they need to. But ideally, you'd be getting relief for at least a few weeks to a few months.
And as you kind of talked about too, this is really individualized to that patient as well,
Correct.
depending on the response.
Correct. So we typically, the ketamine protocol that I follow here is to start at a standard starting dose. And then depending on the patient's tolerance as well as their response to the ketamine, we can make adjustments, whether that includes increasing the dose at the next infusion or reducing the dose.
We've got another question here. Can you explain a little bit further about why it's so important that we recognize CRPS early and focus on those early interventions? And what happens if we don't?
That's a good question. So the reason why it's important to find out whether your patient has CRPS early is that the earlier you start treatment, the higher chance you have at either fully resolving those symptoms or having the patient go back to their quality of life with very minimal medication intervention. The age-old saying, which, if you have a patient maybe in their teens, less than 20 years old, who maybe had an ankle sprain, not healing well, maybe developing CRPS, if that patient is seen by a pain physician and given the appropriate treatment, I would say probably over 90% of the time, they'll have full resolution of their symptoms. If that same patient is not evaluated by a pain physician for months, years, there's a much, much higher chance, maybe even 40 to 50% chance that they will have some lingering symptom throughout the rest of their life. And it could potentially even become more debilitating than that. And so before that sympathetic system cycle has really set in, the faster you can break that cycle with the appropriate therapy and medications, the better chance you have at completely resolving it.
Well, and you mentioned too during your talk that if it remains unresolved, it can spread to other extremities too.
That's correct. So in my experience, I have seen a fair amount of cases that came in with maybe, symptoms in the foot and ankle after surgery or after an ankle sprain. And, a few years later, from the left foot, it went to the right foot. There have been some instances where it has even traveled from the lower extremities to the upper extremities with no other history of injury in any of those affected body parts.
Wow.
So it can very quickly translate and develop into other body parts.
Wow. We'll have to talk offline. I'm fascinated by how that spreads, but we've got another question here. Now, we talked about DRG stimulators, spinal stimulators. Why would a specialist want to recommend implanting a permanent device for something, especially early in that course of disease?
Yeah, so a lot of this has to do with how the patient is responding to the more conservative treatment options. So if the patient has done therapy, has tried the various classes of medications, has even undergone some of the sympathetic nerve blocks, and is not getting relief, the best treatment out there that is currently available outside of these are the neuromodulation devices. And the reason why it's helpful to have that device, which is a permanent device, and I know it's a large undertaking, but it has shown to really improve the functional quality of life. You have to keep in mind that with CRPS, a component of this is psychological. People or patients are going to have times while they're handling their symptoms where it's challenging to navigate those symptoms. And so having a device that can give them some sort of pain relief that's consistently present can do wonders in terms of their ability to manage their symptoms when there is a flare.
So you talked about the psychological component of that and how that's so important. Speak to a little bit, especially as someone who deals with chronic pain, how the patient frustration over the process or lack of progress leads to a worse outcome.
Yeah, that's a good point. Good question. This is something that is definitely a challenge when we're taking care of patients with CRPS. I briefly alluded to this, but many times patients are coming to a specialist after seeing multiple physicians who, in one form or the other, the patient's perception is that the physician didn't listen or that they don't believe them. And so they already have this negative connotation and maybe are not as interested in following through with another physician's recommendation. It does become a challenge for us to work through that. The key thing is to explain to the patient what their condition is, and trying to explain to them that if not treated early and if they don't fully participate wholeheartedly with the treatment options, these symptoms can worsen and can be very debilitating. I think a lot of times either physicians don't know that the patient has CRPS, or they sugarcoat it, or they skirt the issue at hand. And when I've had conversations with my patient, going back to what I said, I like to be honest, I like to be direct. Sometimes it may not be what the patient wants to hear, but it's better that they know what they're dealing with so that they can wrap their head around what type of treatment options are there and what can be done so that they can get better faster.
Got it. You talked a little bit about, too, the role of opioids in CRPS, and I know, as human beings, if we have pain, our first instinct is to, I want to take something for the pain,
right.
But that's not necessarily means to an end, is it?
No, it's not. As a pain physician, of course, opioids have a role in treatment of complex regional pain syndrome, but that role is very limited. It's more in the very acute phase, typically in the patients who are having these symptoms as a result of some sort of surgery or major injury, trying to just get their acute pain down because you don't want that response to get out of hand. But long-term management of these symptoms with opioids is really where you get into trouble, because it's, at the end of the day, it's a nerve-related dysfunction, nerve-related disorder, and opioids are not as effective at treating nerve-related pain. And so in reality, what will happen, more likely than not, is that patients will just require higher and higher doses of opioids, higher classes of medication, and then, providers are going to be at an impasse. Either they won't want to prescribe that higher dose or they don't know where to go next. And these patients are already on some habit-forming medications. And so it's, a passion of mine to try to prevent that from happening. I'd much rather even opt to do a neuromodulation trial rather than subjecting a patient to long therapy of opioids.
One, as a healthcare provider, you're now, the government watches your prescriptions and will, I'm sure, not be shy about reaching out to you if they notice that that's above and beyond their normal treatment protocols. Constance had a question about, is it possible to have full body CRPS that some people claim?
It is possible. Like I said, most likely or most often it's as a result of an injury in one or more body parts, and then those symptoms have moved on to other areas. It typically does affect more of the distal extremities. So, think of your lower legs, foot, ankle, think of your arms, hands, etc. But if it does spread, you could have, the burning, tingling, numbness, paresthesia type symptom present and felt throughout the body, because it's ultimately revving up that sympathetic system throughout the body. So patients may come and say, I have full body CRPS.
So kind of to your point before, if it goes unresolved, it can spread to other limbs. So how exactly, or maybe not how exactly, but what's the process of that spreading to an unaffected limb? How does that process kind of progress?
Yeah, so what typically happens is that you have a set of nerves that are impacted from whatever that original injury or insult may be. And that started the process more locally there. But at the end of the day, all of those nerves come together into the back part of your spinal cord. And ultimately, these fibers communicate with one another as they go up into the brain. And again, there's different connections that are happening at the brain. And then the same signals are then sent down from the brain to these various nerve fibers. So a lot of that cross-linking, cross-communication is where the other nerve fibers that may not have been impacted start developing more sensitivity and ultimately develop similar symptoms.
So I get the advantage of seeing everybody's name that is on here, and I recognize a lot of physical therapists that I deal with on here too. You touched a little bit on physical therapy, but can you explain a little bit more the role of physical therapy in the treatment of CRPS?
Sure. So the key components of physical therapy that are important is one, getting the affected limb as well as the entire body more mobile. Many of these patients, like I said, have pain that's out of proportion. So they're very hesitant, very reluctant to do much of any activity or very minimal activity. So to continue to encourage them, even if it's a small progress, because keeping those muscles, tendons, nerves more active is going to be important. But the other component, which is where physical therapy for CRPS is different, is the desensitization. Because nerves are the ones that are impacted here, and many times patients have some level of hypersensitivity, allodynia, hyperalgesia. It could be to light touch, it could be to various types of material. To retrain those nerves to tolerate those symptoms, you have to do it in a slow, graded manner. And that's where physical therapists can really help. There's a whole sets of protocols on how to do that. And at the end of the day, this is a key component of quality of life. I mean, if you imagine if you had CRPS and you can't tolerate having socks on your feet and you live in a cold weather environment, you can't tolerate the bed sheets scraping against your leg, you can't tolerate sleeping, you can't tolerate shoes. It impacts your ability to go out. I mean, I've seen, some cases where patients say they cannot step out of their home without a certain type of shoe, and even then the temperature has to be within a 10-degree difference, because anything hotter or anything colder really sets them off, and they're very sensitive. So if the hypersensitivity can be addressed, it could really lead to a significant improvement in their quality of life.
If anyone does have any additional questions, the questions so far have been great. We really appreciate those. And we are coming up to about 1 o'clock. So please, now is your time to get those questions in. Shannon was wondering if patients dealing with ongoing shoulder pain post-rotator cuff repair might find value in consulting with an interventional pain specialist. Additionally, could you share some insights into the potential interventions and strategies that could be explored to alleviate their discomfort?
Yeah, that's a good question. So it would depend on the constellation of symptoms. Of course, if they're still having pain after shoulder surgery, if they have enough of the symptoms on history and physical exam to have CRPS, then of course you treat them as such. But other times, for post-shoulder surgery related pain, a lot of times you have nerve entrapment, suprascapular nerve, etc. You have your entire brachial plexus that's coming down from the neck into the shoulder. And sometimes those nerves can get jostled around. And so there is a role of, either doing targeted nerve blocks, or more recently, peripheral nerve stimulation has been done. So it's kind of a similar concept to the spinal cord stimulator that I discussed, but instead using a much smaller catheter placed right next to that nerve that is impacted, and using a small transmitter to try to change how that nerve sends the pain signal. So there's definitely a role of having these patients evaluated. Just depends on where their pain is and the symptoms that they're having.
So if you have any takeaways from today, Early intervention, probably top of the list.
Yes, definitely.
For sure. Any last questions? Thank you. So, Eileen popped one in there. This is a great one. So, do you have any, Eileen's question, do you see a lot of patients with CRPS after cast applied too tightly on ankles and wrists?
Yes, I do.
You know?
It is, it can happen because that could almost present kind of like a sprain, strain, or quote unquote crush injury. I mean, I know that the nerve is unlikely to get avulsed from that, but if you have a part of your body that is still recovering from surgery, there's some level of swelling. Now you put a very tight cast on that. The various compartments within that extremity are going to get tight, and they're just going to put more pressure on the nerves, and then that could be enough of an impetus to start that whole cycle.
Wow. Just a couple of minutes left. If you do have a last-minute question, please go ahead and enter that. Dr. Shah, thank you again for taking the time to do this. This is fascinating, and as I've said a couple of different times in email correspondence, this has been a requested topic on every single webinar we've ever done. So I'm so glad that you were willing to kind of enlighten us and talk a little bit more. I want to thank Paul Strandquist, who helped set this up, and his assistants getting this out to all of you, and thank all of you for spending your lunch with us, especially in a Friday afternoon. That is huge. We really appreciate that. Please feel free to email or call if you need any additional information about workers' compensation at Ortho Illinois, or if you have any questions or concerns. Again, my email is billc@orthoillinois.com. I hope everyone has a great Friday, and thank you very much for your time. Have a good day.
Thank you.